we want to appreciate him for joining us this evening, and we appreciate each and every one of you for taking out time to participate in this series. Dr. Rohit is a gastroenterologist in Springfield, Massachusetts, and he's affiliated with the Bay State Medical Center. We're pleased to tell you he's also the Director of Research in the Division of Gastroenterology, and he is an Assistant Professor of Medicine in Tufts University. He did his med school in All Indian Institute of Medical Sciences, and he has a master's degree in epidemiology at the Harvard School of Public Health. His main interests are in IBD and quality outcomes in endoscopy, and he has won numerous awards and has written several articles. We want to appreciate Dr. Singhania for joining us this evening, and we want to appreciate each and every one of us for coming online. Please note that the lines are muted right now, and then after he has finished his presentation, we will unmute all lines so that you can ask as much questions as you want. Also note that you can also type in your questions so that Dr. Singhania could respond to them once he has finished his presentation. I'll be handing over now to Dr. Singhania to introduce himself as well and then begin the presentation.
Thank you, Muzo. Can you hear me?
Yes, we can hear you, Dr. Singhania. You are presenting now.
Okay. I'm just sharing my desktop, so. Can you see the slides?
Yes, we can see your slides.
All right, great. So thank you very much to Muzo, Dr. Ashish Atreja, Dr. Bruce Sands, and the whole Mount Sinai team for giving me the opportunity to present as part of the HealthPROMISE consortium webinar. And so today I'll be talking about pouchitis and inflammatory bowel disease. I am based in Springfield, Massachusetts at Bay State Health in the Division of Gastroenterology. I'm a practicing gastroenterologist, and I also participate in research here. I have no conflicts of interest relevant to this presentation. So I took the opportunity to divide the talk into portions as outlined here. We'll first talk about indications, surgery, and anatomy of pouches. So the most commonly used pouch surgery is ileal pouch anal anastomosis, and this is the J pouch. The main indications for forming this pouch are surgery in ulcerative colitis. This is done for medically refractory disease where the symptoms are uncontrolled despite maximal therapy from steroids, mesalamines, biologic therapies, and immunomodulators. Fulminant disease is extremely severe disease which is rapid in onset and fortunately very rare and is again unresponsive to medical therapy. And for dysplasia and cancer, when a patient has cancer, then they need colectomy or removal of the colon. The 25-year colectomy rate in ulcerative colitis is about 30%, and most of these patients now are evaluated and for pouch surgery. So the ileal pouch anal anastomosis is done by two techniques, the hand-sewn technique and the staple technique. The hand-sewn technique I wanted to briefly review here and followed by the stapled anastomosis because these both have important implications in how the pouch is maintained, managed, and surveilled. So as part of the hand-sewn technique, a total abdominal colectomy is done, which means removal of the whole colon at the time of the surgery. Complete distal rectal mucosal resection is done. This is probably the most important part differentiating this from the other approach, where the rectal mucosa is stripped off from the distal segment and a J pouch is formed, followed by this ileal pouch anal anastomosis, which is basically means joining the J pouch to the anal canal. And this is sutured to the dentate line, and that's why the word hand-sewn. And a diverting loop ileostomy is created, which is basically a defunctioning ileostomy. What that means is that all of the stool is diverted for the first several months through a stoma or an opening in the abdominal wall to give the anastomosis or this area to heal up before it can be used for regular function. And 3 months later, that ileostomy loop is closed and the functioning through this pouch is restored. The other technique that is more commonly used nowadays is the stapled ileal pouch anal anastomosis without mucosectomy. How this is different from the other technique is by the presence of this rectal cuff. This is a 2 to 3 centimeter rectal mucosal segment that is left behind, and the staples are applied to this, and the J pouch here, as you can see in this diagram, is anastomosed to this cuff. This leads to better outcomes from the surgery, and it's easier to perform and less time consuming. However, as you can imagine, if we leave some of the mucosa, which is basically the colon mucosa, then the risk of cancer and risk of recurrent disease, which is also called cophitis, remains. Now, theoretically, you would say that the hand-sewn approach is better because we remove all of the colonic mucosa, so there's no inflammation and no risk of cancer. However, in reality, what happens is small islands of mucosa can always be left behind, and they are left behind, and practically there is still evidence of inflammation and cancer occurrence in these pouches or in these cuffs. So that's why staple technique is preferred. And coming to the anatomy and configuration of the ileal pouches, there are several kinds: the J, the S, the W pouch, and the cock pouch or K pouch. The J pouch, as you can see here, is the most common. The S pouch is used in certain circumstances where the patient is obese or they have a short mesentery. And so as you can see here, there's an efferent limb that is about 2 centimeter in size, and this helps with the anastomosis. The W pouch is no longer used anymore. It was used in the 1980s, so it's not constructed anymore. The K pouch is used when the anastomosis cannot be made to the anal sphincter due to anal sphincter dysfunction. And so, but the most commonly used is the J pouch. I would like to bring your attention to certain anatomical aspects which we'll be talking about later on. These are the afferent limb here, the pouch inlet, the tip of the J, the efferent limb of the J pouch. So coming to the outcomes after the ileal pouch anal anastomosis surgery, of these, the J pouch, we are now talking about the J pouch, which is the most common surgery. The quality of life after ileal pouch anal anastomosis has been studied over the short and long term in several studies, and this is excellent. The main outcomes after the pouch formation for ulcerative colitis are pouchitis, pouch failure, Crohn's disease, inflammation of the cuff or cophitis, and irritable pouch syndrome. And I'll go into more detail subsequently. Pouchitis occurs in about 25 to 60% of patients over the course of their pouch, and occurs in at least one episode of pouchitis occurs. However, in many patients this happens recurrently, and between 5 to 60% of patients can develop recurrent chronic pouchitis. This fortunately responds to antibiotic therapy, and a very small majority of patients or very small minority of patients develop chronic antibiotic resistant pouchitis in about 5 to 10% of patients. The other outcomes that we just talked about, pouch exclusion or removal, occurs in about 3 to 6% of patients. The diagnosis may be changed to that of Crohn's disease in 2 to 13% of patients. Cophitis or inflammation of the rectal cuff occurs in about 5% of patients, again a very small minority of patients. And the irritable pouch syndrome occurs in about 40% of symptomatic patients. The irritable pouch syndrome is basically the symptoms of pouchitis, which I will talk about in a little bit, but without evidence of inflammation in the pouch. Coming to pouchitis, which is the main portion of the talk, we'll talk about the risk factors, the clinical features, definitions, differential diagnosis, testing, and treatment of this condition. The main risk factors involved in pouchitis, which is basically inflammation of the pouch, are extensive ulcerative colitis at the time of surgery, ulcerative colitis associated with backwash ileitis, which basically means that the inflammation of the colon is flowing into the ileum or the small intestine at the time of surgery. So their ileum portion that is converted into the J pouch is already inflamed. Patients who have extra-intestinal manifestations, especially primary sclerosing cholangitis or abnormalities of the liver enzymes and the liver cells. Patients who use NSAIDs, namely the ibuprofen, naproxen, etc. They have higher risk of pouchitis. Patients who are non-smoker, patients whose blood test is positive for p-ANCA, and some patients who have genetic susceptibility, mainly the IL-1 receptor antagonist, the NOD CARD15 receptor. And so these patients are specifically more susceptible, and it has been shown that they have higher occurrence of pouchitis. Coming to the main clinical features for pouchitis. So remember, when a pouch is formed in a patient, their baseline stool frequency is different than a normal person. They have, the baseline is about 4 to 5 bowel movements during the day and 1 to 2 bowel movements at night time. So at baseline, they have higher bowel movements, but they have good control of this. They can, and they control the timing and evacuation of this due to the formation of the pouch, which is the reservoir of stool. However, once patients start to have problems with pouchitis, their stool frequency increases. Their stools become more liquid, so it's difficult for them to retain these stools. There is urgency and tenesmus, which is a sensation of having to go to the bathroom to pass stools again and again. They start experiencing cramps. Sometimes they also have incontinence, and less commonly they can experience fever and bleeding. These are all common symptoms with pouchitis. However, they're not very specific that they can tell us what is the cause of the pouchitis. So pouchitis has several definitions based on duration, pattern, and response to antibiotics. This is how we classify it. The duration, acute versus chronic, is basically if the pouchitis duration is less than 4 weeks, then it's called acute, and more than 4 weeks is chronic. The pattern can be classified into infrequent, relapsing, or continuous. And based on the response to antibiotics, it can be responsive, where short course of antibiotics for 2 weeks will cause complete improvement in symptoms. That's called antibiotic responsive. Antibiotic dependent is where it is responsive, but as soon as we stop the antibiotic therapy, the symptoms of pouch inflammation or pouchitis come back. And then there is the refractory form, where no degree of antibiotics helps to relieve the symptoms. This is a very difficult and a worrisome development in patients with pouch, and this is called chronic antibiotic refractory pouchitis, or CARP, C-A-R-P. Diseases, again, going over the diseases of the ileal pouch, they can be several. They can be surgical and mechanical, which can happen immediately or late after surgery, namely mainly strictures, leaks, fistulas, which are abnormal connections between the pouch and the surrounding organ, sinuses, abscesses or infections, and adhesions, which is basically attachment of the pouch to the surrounding structures. Then we can classify it into inflammatory or infectious, whereby is the pouchitis or idiopathic pouchitis, which is the most common outcome after pouch formation. They can also have Crohn's disease, cuphitis, which is inflammation in that last cuff, last portion 2 to 3 centimeter, where ulcerative colitis can occur again, the inflammation can occur again. They can have small bowel bacterial overgrowth, CMV infection, C. diff infection, and inflammatory polyps. Functional symptoms can also occur in the pouch. Patients can suffer from irritable pouch syndrome, pelvic floor dysfunction. Also, they can develop dysplasia, adenoma, and cancer in the pouch, which is being increasingly recognized, and that's why surveillance pouchoscopies are recommended to monitor for recurrence of cancer or occurrence of cancer in these pouches. These patients also tend to suffer from anemia osteoporosis or vitamin D deficiency, and sometimes vitamin B12 deficiency, and they can have malnutrition. So this is a broad spectrum of what these patients can experience. And to help with the diagnosis, the endoscopy is the most valuable tool. It's called pouchoscopy with biopsy. So basically, a camera at the end of a tube is inserted just like a colonoscopy from the rectum into the pouch, and the various areas, the afferent limb, the inlet, the J-tip, the mucosa of the pouch, and the cuff, they are examined in great detail and biopsies are taken. This is the most important test in assessing the pouch, making a diagnosis, and then helping treat it and surveillance and to surveil the pouch. Pouchography is another test that is used. This is based on X-ray images of the pouch with a water-soluble contrast to assess for any leaks, to assess for pouch compliance and stiffness. Pelvic MRI is helpful in evaluating for fistulas. MR enterography and CT enterography, which are special techniques of imaging of the pouch area through magnetic resonance or computed tomography. These are helpful in assessing for inflammation, abscesses, or fistulas again. Exam under anesthesia helps rule out Crohn's disease or strictures. Anorectal manometry and anorectal ultrasound are used to assess for anal sphincter problems in patients who develop incontinence. And then pouch emptying study is again used to assess compliance and stiffness of the pouch. So these are several modalities that are available to us, but the most important again is endoscopy, and usually the first study done in addition to the laboratory and stool testing that is usually performed in these patients. But imaging studies also have their role in specific situations to assess for pouch disorders, and they help in management of these diseases. So just to go over some images, so normal endoscopy of the pouch or normal pouchoscopy looks something like this, where you can see the owl's eye appearance of the J pouch on the upper left, and the various parts of the pouch. The mucosa is nice and pink and appears very healthy. In contrast, when pouchitis occurs, they start to develop small erosions or ulcerations, as shown in the cartoon here, throughout the pouch. And on the right side, on the top, you can see those erosions. And at the bottom, you can see severe inflammation throughout the pouch, where it appears red, dark, ulcerated, and severely inflamed. Other pouch disorders, again, are shown here. And as you can see on the bottom left, there is a clear line of demarcation from the inflamed or ulcerated areas, and there's a normal mucosa. This is a sign of ischemic pouch, or where the blood supply to the pouch is being affected. On the right lower end, you can see there's a polyp developing from chronic inflammation of the pouch. And the above two images show a normal pouch on the left hand and a severely inflamed pouch on the right. Again, sinuses can develop as in the figure A. And I would like to bring your attention to figure D. These are volcanic lesions, and these are typical of C. diff infection. That's a appearance. So apart from the stool testing for C. diff, we can also diagnose that on endoscopy and tell what's the cause of this inflammation. Now, treatment for acute pouchitis is, there are several options, but the most reliable and the most commonly used is the antibiotic therapy, single antibiotic regimen. Ciprofloxacin and metronidazole are both very effective therapies. They can also be used in combination. Some of the other antibiotics have been tested in certain trials, and they have proven to be quite useful. Budesonide and mesalamine are reserved for autoimmune pouchitis disorders or pouchitis where it's not responding to antibiotic therapy. Steroids can be used, and probiotics and fecal microbiota transfer is also being used more recently for treatment of pouchitis. So this is an algorithm where once the pouchitis is diagnosed, antibiotic treatment is performed with single antibiotic therapy at ciprofloxacin 1 gram per day or metronidazole 1 to 1.5 gram per day. As you can see on the left, Antibiotic responsive pouchitis means that it responds to 2-week course of therapy and the patient gets better. Their cramping resolves, their diarrhea or excess diarrhea, should I say, resolves, and they feel much better. And then the only thing that is needed is repeat therapy as needed. This occurs in the majority of patients. And some patients, however, develop antibiotic-dependent pouchitis, whereby repeated courses of antibiotics are necessary and sometimes probiotics are used. Probiotics like VSL number 3 and lactobacillus can be used to maintain the pouch in remission, and this can help to reduce symptoms. And the third category is antibiotic refractory pouchitis. This is a very worrisome category because this does not respond to the standard treatment by antibiotic, as is evident from its definition. So then, it is recommended to look for other causes of pouchitis. And sometimes it can be pathogen induced, namely where there's a bad pathogen that's causing that infection. So CMV is checked for, C. difficile is checked for, and blood tests are drawn to do this. And based on the findings, it can be treated by antiviral therapy like vancomycin, and C. diff is usually treated by vancomycin or fidaxomicin. Vancomycin at this point is the first line treatment for C. diff infection. In some cases, fecal transplant can be helpful in recurrent infection. Again, one point of importance is to remember here that the pouch mucosa is the ileum or the small bowel mucosa. Small bowel mucosa usually should not be developing C. diff because C. diff attaches only to colonic mucosa cells. And so if the colon has been removed, you could question why is C. diff occurring in these patients. And so this is a new finding in these patients that due to pouch formation and stasis of the fecal material in there are changes that are induced in the pouches. The bacterial population in the pouch is altered, leading to dysbiosis, and the immune mechanism or the cells that fight infection are altered. It is also now known that the pouches can develop colonic metaplasia, or their cells can change into those of the colon in response to the fecal stasis. And so they have cells that resemble large intestine or colon, and that's where C. diff comes in. Now, if the pathogen-induced pouchitis is ruled out by stool and lab testing, then we start to look for immune-mediated pouchitis, where the patients, where the initial process that caused Crohn's disease and ulcerative colitis, and that's not clearly understood, is again acting in a similar way on the pouch and causing either PSC-associated or IgG4-associated or autoimmune pouchitis. These generally respond to mesalamine or budesonide therapies. These are difficult to treat, so sometimes immunomodulators and biologics are used. There is very little data on the use of biologics at this time for these kind of conditions. I also wanted to mention the role of probiotics since it's a frequent question. And so role of probiotics has been studied in pouchitis. In fact, there are trials showing primary prophylaxis to be effective and secondary prophylaxis to be effective. Small studies with VSL number 3 at a high dose of 6 grams per day and Lactobacillus rhamnosus have shown efficacy to prevent pouchitis from occurring, even for the first time. So primary prophylaxis means basically to treat, to prevent the first episode of pouchitis. And secondary prophylaxis is once the pouchitis has occurred or inflammation of the pouch has occurred, it has been treated with antibiotics, then to prevent recurrence of the inflammation of the pouch, high-dose VSL number 3 has been studied at a dose of 6 grams per day, mostly in European studies, and it has been shown to be effective in maintaining antibiotic-induced remission in patients with persistent pouchitis. However, these are still being studied, and most of these studies were conducted in Europe, in some Italian population, and so more data is needed to systematically recommend these probiotics in various guidelines. So role of fecal microbiota transfer, so what's happening on this scene, as this is really gaining a lot of attention in the media. So studies have been done and they've shown modest efficacy in ulcerative colitis. However, most of the very minimal data is available for pouchitis, but I did find a study done by Dr. Stalmack in the American Journal of Gastroenterology. This was published as a letter in 2016, where they treated a small number of patients with fecal microbiota transfer, and they had very, very good outcomes. And so this appears to be promising, but more data are needed to further evaluate this, the role of these, of fecal microbiota transfer. I also wanted to talk briefly about my study that we did at Mayo Clinic, Rochester, when I was a CCFA fellow, a visiting fellow at Mayo Clinic with Dr. Pardee and Dr. Loftus and their team. This was basically to study the occurrence of pouchitis and other pouch dysfunction in a population-based study. So its aim was to describe the incidence and natural history of pouchitis and other forms of pouch dysfunction in a population-based cohort. So 35% of all pouches in the study developed chronic pouchitis, and 19% of all pouches had at least one evidence of acute pouch disorder. Treatment response in patients with pouchitis, majority of the patients were responsive and or antibiotic dependent. About 20% of patients were refractory to pouch therapy, similar to what we know at this time to be valid. And cumulative probability of pouchitis seemed to increase over time. I would like to talk about Allie's law a little bit in context of IBD, and especially with pouch disorders. So does anybody know what Allie's law is? So this law is actually approved and in force in 16 states, including Massachusetts, where I am. And it is called the Restroom Access Act. This is named after Allie Bain, who was a 14-year-old girl who suffered from Crohn's disease, and in a Chicago shopping mall had an accident when she couldn't find a restroom, or some people wouldn't give her access to the restroom. And she decided to fight for her rights and for people who had IBD. And subsequently, on August 4, 2005, this bill was signed into law as the Restroom Access Act. It basically requires that retail establishments that do not have public restrooms, they provide access to employee-only restrooms. This is a huge boon for patients with IBD who have frequent, unpredictable bowel movements, and this as much applies to patients with pouchitis who may have an even more need to for public restroom access. So there are medical alert cards available from CCFA for IBD patients, which can be used to gain restroom access when required. Coming to conclusions, the majority of patients with ulcerative colitis or indeterminate colitis who had a J pouch formation had some form of pouch dysfunction. The most common form of pouch dysfunction was pouchitis, and up to 35% of patients developed chronic pouchitis, and most patients with pouchitis responded to antibiotic therapy. And thank you to HealthPROMISE Consortium for giving me the opportunity to talk today. And I hope more people use the app and we can do a great job at that. Thank you.
Thank you so much, Dr. Rohit. Thank you so much for speaking to us.
Oh, you're very welcome.
We want to appreciate those people who have just joined us and those who have joined from the beginning. And we want to let you know that all lines are going to be unmuted. I see that there are already some questions that are typed. So I would want to ask Dr. Singhania to please, if you could go through some of the questions that are being typed. And at the same time, I'm going to unmute the screen and unmute the speaker so that we can ask as much questions as we want.
Yes. So I do see that the one question is, do you change your diet when you have pouchitis? If so, what kind of diet works? And so yes, that is correct. You know, there is some data and some recommendations that when a pouchitis is occurring, a low carbohydrate and a low fiber diet is effective in controlling the symptoms and reducing the carb load. So I would suggest that you definitely try that. So low carb, low fiber diet. Another question that I see here is any natural remedies to treat pouchitis? This is a good question. I wish I had a better answer, but for now, the data that we have would include using VSL number 3, a probiotic, and Lactobacillus rhamnosus. These VSL number 3 has 4 major genera of bacteria in there and does benefit some patients. All the data is from Europe and from an Italian population mostly, but it is worth giving it a try for sure. So those are the questions that I have at this time.
Thank you so much, Dr. Singhania. Please, I want to indulge everybody to know that the lines are open. Feel free to ask any questions you have. We'll keep the lines open for another 3 minutes. Thank you. I see a question coming. Dr. Sangani, I don't know if you could please answer the question that was just typed.
Yes.
It says, what are the side effects of
flagell? Yes. Very good question again. So antibiotics are not without side effects. The main side effects from flagell are altered taste in the mouth, especially metallic taste. Also, you have to be careful um, that alcohol and flagell do not mix well, and it inhibits the liver enzymes which metabolize alcohol, so your alcohol level can be very, very high when you're taking flagell. And third, and very important, is neuropathy or tingling sensation or numbness in the nerves, mostly with long-term use of flagell. And so that's something to remember. People who use multiple courses of flagell over several months, they could develop nerve problems. And if that happens, then the best recommendation is to stop flagell therapy. That is usually seen with higher doses of flagell. So one option is to use slightly lower doses of flagell, and that can be helpful. Other than that, nausea, vomiting, abdominal pain, headaches can occur with any antibiotic therapy and could also occur with flagell.
Thank you so much, Dr. Singhania.
Oh, you're welcome.
Are there any other questions? Please feel free to ask your questions or type them in, while we give 1 more minute for any other questions that are coming in.
You are very welcome, Sean. Please feel free to contact me if you have any further questions. Thank you very much.
Sure. Thank you, Dr. Singhania. We want to appreciate all the participants that have joined us today. We want to appreciate also Dr. Singhania that has joined us from Springfield. We want to note that this recording, please, is still available, and we'll put it in our newsletter that is coming up from the next month. So even if you have missed it now, I see some people have already sent out messages saying that they want the recording. Please kindly note that this will be on our next newsletter. Also, we want to say stay tuned for the next webinar. And for the upcoming events, I think there's the Advances in IBD that is coming up in December 2016. And then we have the IBD Awareness Week, which is from the 1st to the 7th of the year. So please feel free to shoot us any email concerning the app and its usage, and we'll be here to help you. Once again, we want to thank Dr. Singhania for joining us this evening, and we thank each and every one of us that has participated.
Thank you, Mahmooza, for conducting this. Thank you so much for the opportunity to talk with everybody. Thank you.
All right. Thank you. Have a good night, everyone.